I'm going to talk about dry eye disease in glaucoma this morning. And we know that before this advent of all these SLT mix and all these things, we've all been using medication, as Dr. Idowu has just said. So we know that glaucoma is a chronic disease. And as a result of that, we've been using medication over the years and in a continuous manner. I mean, for many years, patients are placed on medication. And so for this reason, glaucoma patients are exposed to toxic effects of this medication. My first slide, please. So as I mentioned earlier, that topical treatment of glaucoma is often required for several years. And studies have indicated that patients with glaucoma who are on medication have ocular surface disease ranging from about 48 to 83% based on previous study. And the ocular surface disease is leading cause of poor medication adherence and treatment failure in many of our glaucoma patients. So ocular surface disease significantly impacts glaucoma management by affecting patients' comfort and quality of life. There is decreased adherence to treatment and treatment efficacy, and negatively impacts glaucoma filtration surgery outcomes. Many clinicians we have underdiagnosed and overlook the impact of OSD in glaucoma patients. Mentioned earlier, we have about 48 to 83% incidence of OSD in patients on medical treatment for glaucoma. More common in patients on long-term therapy, usually over 3 years of use of glaucoma medication, and those on multiple eye drops, and usually found more commonly in older adults, and females have a higher risk of developing OSD. Medication-related risk factors, we are talking about epidemiology now. We know that the preservatives in most of our medications are usually methaconium chloride based, and this is found to have toxic effects on the ocular surface. Multiple medication increases exposure to preservatives, and we know that some of these eye drops, they have different rates of toxicity. It's known to be more common in people on latanoprost, beta blocker than nitazoxanide. Systemic factors, risk factors include age-related cases of tear film dysfunction, like we see in Merman gland dysfunction. Then autoimmune diseases, like people with Sjogren's disease, rheumatoid arthritis, are known to have ocular surface disease, and they can be complicated with the use of glaucoma medications. Then environmental and lifestyle factors. Then prolonged screen time leads to dryness of the eye, and then can worsen ocular surface disease in patients with glaucoma. Then dry environments, like what you have in places with low humidity, in places with harmattan, air conditioning, and reduced blink rate. Next slide. So impact on treatment, adherence, and disease progression. OSD symptoms reduce patients' adherence to glaucoma medication. Non-compliance rates of up to 50% patients with severe OSD symptoms have been documented. Non-adherence can lead to worsening of IOP control, increasing risk of glaucoma progression in patients with OSD. Surgical intervention requires sooner or at a later higher rate in patients with OSD due to medication intolerance and treatment failure. The next slide, please. So what is the pathophysiology? With chronic exposure to preservatives, there is alteration of the ocular surface microenvironment. Which is the most common preservative in most ophthalmic pharmaceutical, induces toxicity, oxidative stress, inflammation, and type 4 hypersensitive reaction. This is a non-specific antiseptic detergent that acts by disrupting lipid bilayers. So preventing colonization by gram-positive and gram-negative bacteria and fungi. And this also injure the ocular surface cells. So BAC causes corneal epithelial damage by inducing apoptosis of corneal epithelial cells, the globular cells, meibomian gland dysfunction, and destruction of mucin layer, leading to poor tear film spreading and tear film instability. So this is what we see in the mucin layer of patients that have been on chronically on anti-glaucoma medication with the back contents of the various medication in different percentages, and this is the extent of the destruction to the mucin layer. Next, please. So when we talk of the inflammatory cascade in ocular surface disease, what happens is that there's trigger of pro-inflammatory cytokine release, leading to conjunctival hyperemia, subclinical inflammation, and epithelial apoptosis. Ocular surface remodeling occurs with squamous metaplasia of the conjunctival epithelium, leading to keratinization and chronic irritation. Corneal nerve damage occurs, and this reduces blink reflex and exacerbates dry eye symptoms and signs that we see in patients with ocular surface. So these are the symptoms of ocular surface disease: ocular discomfort, burning, stinging, irritation, foreign body sensation. They feel like sand in their eye, the eye becomes gritty, and there's reflex tearing, and the eye feel dry. Next. Then we have some signs that we see, especially in patients with meibomian gland dysfunction. We have clogged orifices, telangiectasia of the eyelid margin, conjunctival hyperemia, papillary or follicular conjunctivitis in response to preservatives. Then there's reduced tear breakup time, punctate capillary erosion on fluorescein staining, and reduced tear meniscus height on slit lamp examination. Sorry, my next slide. So this is just a picture of an eye with inflammation from ocular surface disease. You have corneal erosion. The next slide, please. So differential diagnosis of ocular surface disease. You can see that I mentioned keratosis conjunctival seke, neurotrophic keratopathy, and decreased corneal sensation. My next slide. So evaluation, slit lamp microscopy, conjunctival evaluation, corneal evaluation, and tear film test. Next. Then advanced imaging and diagnostic tools as non-invasive tear breakup time, meibomiography, and infrared imaging of meibomian gland loss, impression cytology, inflammatory biomarkers have been demonstrated. Next. So management strategies, general principle, modification of glaucoma therapy, ocular surface optimization, patient education, and lifestyle modification and procedures and surgical intervention. So we have to prioritize preservative-free or low toxicity formulations for our medication, then treat underlying eye disease and meibomian gland dysfunction. Next. The modification of glaucoma therapy, as mentioned earlier, we switch to a low drop frequency and cumulative preservative exposure. We can consider SLT as been mentioned and mixed procedure. They use preservative-free drops. Ocular surface optimization, use of artificial tear drops of different types, and anti-inflammatory therapy. We can even use cyclosporin A for such patients with ocular surface disease, lead IG and one compress for meibomian gland dysfunction. Management strategy for patients, changing of patients' education and lifestyle modification. Lifestyle modification, hydration, screen time reduction, and use of omega-3 supplements. Then surgical alternatives, I mentioned earlier, SLT, mix and filtering surgery can be used to reduce exposing patients to anti-glaucoma medications. So we have recent advances and future direction. So the use of artificial intelligence, OSD, and glaucoma management. We have the use of telemedicine-based dry eye assessment to enhance remote monitoring to patients' management. So in conclusion, OSD is a major challenge in glaucoma therapy, impacting adherence, vision, and quality of life and long-term outcomes to glaucoma management. Chronic use of topical glaucoma medication, especially those preserve it back is a significant contributor to OSD. An holistic approach combining glaucoma control with OSD management is essential for optimal care. Thank you. The goal is not just IOP, but preserving vision and quality of life.
Thank you very much.